Welcome to Dateline Health. It's Fred Lippman coming to you from Nova Southeastern University. Again, I always tell you that this is your show, and we've had a lot of questions about lower extremity pain, particularly foot and ankle. And to tell you the truth, I didn't know until we searched around that we had such a complete entity at a particular hospital here in Broward County that had a foot and ankle surgical treatment specialty clinic. So I'm going to introduce Dr. Clive Woods, who's an orthopedic surgeon, and his specialty is foot and ankle. So tell us, how are you, number one?
I'm doing fine, and yourself?
Good, sir. And tell me where your practice is.
So my practice is located on Broward Boulevard between University and Pine Island, so it's right in front of Westside Medical Center.
And you're working with Michael Smith, who's in front of me, who is a physical therapist. We're very proud of our registered physical therapists. And you're at University Hospital Medical Center, and where is that located? Up on?
That is in Tamarack, so University Drive and McNabb.
So let's just talk about the traditional person that you work with.
Yeah, so I work with, from age groups 10 years old all the way up to 90 years old. And as a foot and ankle surgeon, some of the common conditions that I deal with is plantar fasciitis, which comes from walking, all the way to just ankle fractures. You're walking, you trip, you break your ankle. The one thing I do encourage a lot of my patients to walk, just for overall bone health. It's the old saying, if you don't use it, you lose it. So things like osteopenia, which is sort of a decrease in the bone quality, and osteoporosis, which is the full-blown decrease in the bone quality. Walking can help that, especially even if you walk with weights, things like that, to help with bone health.
Well, Michael, if I could call you Michael.
Yes.
Michael Smith, as a physical therapist, of course, you've been trained full-body physical therapy. Head to toe. But, it's interesting because somebody related to us last week about having some neurologic back surgery, all right? And they were constantly having pain in their right leg. Obviously, there was some compression on the spine, and it was mitigated by the surgical technique. I can't tell you what it was. But it changed their way of walking, their gait.
Of course.
And immediately the doctor said, we've got to get you to a physical therapist. So tell us what's involved.
Well, so the patient comes in, in this case, they have the pain, the leg pain, so we do a physical therapy evaluation. We find out what their problem is, and we find out what their goal is. So they want to be able to walk better, they want to have less pain. So then we incorporate a plan of care to fix that problem, and that usually includes exercises. We have modalities such as electrical stimulation, ultrasound, heat, cold. A lot of the back pain is exercise. It's core strengthening, stretching, because like you said, the pain down the leg is coming from their back. So we have to get that fixed so that they can walk better.
And Dr. Woods, again, relating to that, a lot of folks don't know why they have pain in their foot and ankle. Yes. Of course, unfortunately, we're at a point in time where the last people in their last quartile of life. Yes. So between 75 and 100, they say that, I got this terrible foot pain.
Yes.
And yet it often relates to a diabetic condition.
Yes.
and other things. So why don't we talk about that?
Yeah. So, I mean, I have patients come in my office plenty of times with foot and ankle issues, and they have pain in their foot. First, getting a clinical history to see what's going on, and in addition to that, x-rays. But sometimes I may have someone that comes in, they have arthritis in their foot, but the symptoms they're telling me, let's say, oh, I have burning on the bottom of my feet, which is causing pain, which is going to be totally, even though they have the arthritis in their foot, that's usually not what's causing it. A lot of times they may have neuropathy, secondary to either one, if they have diabetes. Sometimes you can have what we call idiopathic neuropathy, meaning we don't know why. Sometimes it can be from B12 deficiency, which kind of feeds the nerve, but it's just in a sense, a nerve that is damaged. So they feel this sort of numbness in the foot, and the pattern's a little different. So normally when someone has neuropathy, we call it stocking and glove distribution. So what I mean by that is if you look at your big toe all the way down to your small toes, there's different nerves that innervates for sensation for those toes. But in a neuropathy, all of those toes would be numb. So it kind of, same way you put on a stocking or put on a glove, kind of comes up that way.
It's an interesting thing because you say each toe indicates a different element. Of course, you both know that that we have two medical schools here at Nova Southeastern: the Osteopathic Medical School and the Allopathic, the DO and EMD, and they work hand in glove. Hand in glove. You just put that into my head. Hand in glove with our physicians, and we have a very large sports medicine therapy clinic.
Yes.
Where that is one of the indications. Which toe? It's an indicator as to where they have a problem.
Correct.
Michael, that shows up when you see a patient.
Oh yes, it can tell you what spinal level, if we're talking about the same patient, what spinal level the injury is, or which muscle is, if they pulled a muscle, or
Well, just the other day, I was speaking to someone here. I was just walking to my car, and I noticed that they were, gimping.
Right.
And I said, "What's the matter?" I find out that she went to get an MRI. She had a stress fracture.
Yes.
Not uncommon.
Not uncommon. I see it a lot. Usually the way I kind of diagnose the stress fractures, one, history is a big part of it. So a lot of times when someone says, hey, I have pain in my foot, usually one of the common areas is like your metatarsals, which are sort of an extension of your toes, a little bit closer to the ankle. And they come in and they say they have pain in their foot. I examine them, and what I usually find is when you examine them, when you touch a certain area, it's very point specific because it's right over that fracture. They'll have pain. I follow that up with x-rays. The funny thing about x-rays is sometimes it may not show the stress fracture, or sometimes it may not be a stress fracture yet. Maybe a stress reaction, meaning the bone is weakening, but it has not broken yet. The way I usually follow it up is very simple. I treat it as if it is a stress fracture. So a lot of times they may get a short cam walker boot. So it's like a cast that you can take on and off. And then I have them come back in 2 weeks, 3 weeks, re-examine them, get another x-ray. And the funny thing about it is that when you have a stress fracture, the way bone heals is with callus. Callus is sort of like a glue, and that gets calcified. So you may not see the fracture, but you see the healing. And I see it all the time where, they come back and it's like, there you go, there goes where your fracture was. Even though we couldn't see it on the initial x-ray, the healing around the bone, we can see that and say, yes, you did have a fracture there.
Let me stick with that for a second, because it really was fascinating to me. I mean, I just was trying to say hello to someone. And I guess just came out of my mouth.
Yes.
But, the reality is that a lot of people don't do what I would say, take good care of yourself. I always say that at the end of the show. Take good care of yourself. Tell your doctor everything.
Yes.
So if, they say, well, I got a bad pair of shoes, or I was wearing with women with high heels, and I shouldn't have. I got it started to bother me. The plantar fasciitis.
Yes.
But when people come to you, and I guess Michael also in your review, Is the question made, or is there a concerning issue relative to when was the last time you had a bone density test, particularly in females because of hormonal changes?
Yeah, it definitely is. For me, even though I specialize in foot and ankle, I do general orthopedics. And so one common fracture or two common fractures are wrist fractures and hip fractures. So you're walking, you slip, you fall, you put out your hand to brace yourself and get a wrist fracture. Usually when I see that, I always discuss with them when was your last bone density. The reason why is because if you have osteopenia or osteoporosis, that makes you a little bit more prone for when you fall to break your wrist. And the thing that I'm trying to prevent is the bigger thing, which is hip fractures. Because a lot of times you may fall and break your wrist that first time. The next time you fall, you may break your hip, which is a bigger surgery. So I always try and ask them, when was the last time your primary care has gotten your bone density scan? And if there needs to be something done, then the primary care physician can kind of follow up with that and give them the appropriate management.
I'm going to get right to you, Michael, in just a second, but I got to stay on this one. Mm-hmm. Explain to the people out there what osteopenia is and osteoporosis is.
Yeah. So what osteopenia and osteoporosis is in the sense of the bone, it's the actual density of the bone. One of the ways I try and simplify it with another condition is a lot of people know that, okay, you have diabetes and you're pre-diabetic. And usually that goes on based on a level of your blood sugar. So with someone that has osteopenia or osteoporosis. Osteopenia is sort of like the pre-osteoporosis, and the way we kind of measure that is when you get a bone density scan, they take different levels, whether it's your hip, your back, and going back all the way to statistics, we go based on a standard deviation, so a bell curve. And so what ends up happening based on that bell curve, where you kind of land kind of dictates whether you have osteoporosis, osteopenia. So for example, if you're less than 2.5 for the standard deviation, then we will say, okay, that's osteoporosis. But if you're between that 0 and minus 2.5, then we'll say that's osteopenia.
And how does, when one sees that, whether it be it's so very, very common. It's not gender specific, but it's so very common today to hear from our viewers about osteopenia and osteoporosis in the female gender.
Yes.
Can you try to explain the reasons?
Well, there's not, I mean, what we see, I haven't seen a specific reason, but one of the common gender and age is usually, especially when I see a 50-year-old Caucasian female, they're very, very high chance of osteopenia, osteoporosis. So a lot of times, once again, I try and get them to see their primary, get that bone density, and even going back to when we were talking about walking, walking with some weights to try and, in a sense, increase the load so that the bone kind of gets stronger.
Michael, it's all yours, because now we're in your area.
Right. So going on what he just said, weight bearing is very important for your bone density. The bone reacts to weight going through it, and that it encourages it to replicate so that the bone stays strong, Wolf's theory. Yes. And so, yes, as part of the physical therapy and fitness program, we encourage walking, weight bearing. Pool exercise is great, but it's really good to be up and walking.
It's an interesting thing. You just put a word in which I think is very, very important, because just having physical therapy is just that modality of healthcare. But the fitness issue is the continuum of what you apply.
You have physical therapy for 4 weeks, but you have to keep up with your fitness after that.
Which includes what?
So general fitness, so cardiovascular health, the osteoporosis, so maintaining your bone health. Fitness helps manage diabetes and high blood pressure, which are very common problems. Strength, endurance, nutrition, all part of it.
How about intake of fluids?
Your body functions are dependent on water. All of the chemicals that get transferred from cell to cell, from your blood into your cells, all depends on water. Water transports all of those things. Your neurological signals from your brain get transferred through all the water. So if you become dehydrated, everything goes crazy. So you have to stay hydrated.
So, Dr. Woods, you know, I want to get back to this osteopenia, osteoporosis again, and we won't stay much longer on that. But you know, we've had a program just a little while back with some OBGYNs.
Yes.
And there was sort of an intellectual difference. One was, you know, let's treat osteoporosis, osteopenia, you know, once we see it. And the other one was, let's prevent it. There's more prevention.
Yes.
And that particular person was quite concerned over the many years ago, now it's almost 2 decades, when the use of estrogenic hormones became verboten, you know, going to cause cancer, et cetera, whatever was being said. But there are alternative estrogen supplements that are available. What's your thoughts?
So usually going back to first starting with prevention or treat it when it's there, I'm always big for prevention. Trying to, one, stay healthy, because like we were talking about, walking does so much, you know, from a BMI, I mean your weight, body mass index, cardiovascular, but in addition to that, osteopenia and osteoporosis. So that's usually where I would say starting. Other things that you can do is, you know, from your calcium intake to try and increase your bone density. As far as hormones, a lot of times from my specialty, I kind of deal with the more when the fracture occurs, or in a sense when a lesser fracture occurs, and try and prevent the bigger fracture, which is like hip fractures. But most times when it's dealing with hormones, I kind of refer to my colleagues who are going to be the internal medicine doctors, the OB doctors, and try and, you know, because that's their area of expertise.
I don't know whether you've seen it. Most of the what are called the multiple chain pharmacies are now doing B12 shots. I would assume there's a word out there. Nobody's just going to go in and take a B12 shot. B12 shot's not going to give you super energy, which some people believe. But the addition, the ability of the body to have the B12 be utilized by the body for a purpose.
Yes.
It's not just a vitamin. It's purposeful. You want to explain something?
Yeah, so usually, and there's other, B12 is one, but there's other vitamins that are in that B12, I mean B complex is what we call it. Right. But usually with, sometimes when people have neuropathy, the B vitamins helps with the actual nerves to make them a little bit more healthy. So if you have things such as neuropathy where the nerve is damaged, you know, one of the things is looking at your B levels, and if it is low, things like vitamin B12 can help. So that's usually when I would say it's necessary, not necessarily just taking it. Normally, if you have a nice, well-balanced, healthy diet, you're going to get your, you know, your vitamins, whether it's, you know, your vitamin D, your calcium, your B complexes. But when that level is low and you're having issues from it, usually your neurologist is going to say, okay, well, we got to do B12 shots.
Michael, I know that often with people that might be under your care and receiving your trained skills, you deal with the full spectrum, as we started out the show saying. Dr. Woods said all the way from the youth all the way through the elders. A lot of sports injuries. Did you see a lot of these sports medicine problems?
I don't see a lot of sports medicine working in Tamarack. I get a lot of the mature patients, but that's certainly a specialty within physical therapy and sports medicine doctors. It's the same idea, though. We are focused on function and fixing whatever the injury is and getting the person back to maximum potential, and even prevention. Hopefully someone's working with the athletes and training them correctly so that they don't injure themselves, so they're staying strong and they're staying flexible.
Dr. Woods?
Yeah, so the one thing I would mention for children and injuries in sports, one of the biggest things that, and you'll notice when I say it, is that when we grew up, there was football at this time, there was baseball at this time, there was basketball. The reason why I say that is because when you're doing these different sports, there's different mechanics. So from the standpoint of let's say you're a quarterback, you're throwing a lot. Now you go to basketball season, you're shooting, you're using different mechanics. And what ends up happening is nowadays it is, we play baseball and we're on the travel, we're on the rec, we're on the high school or middle school team, and that's a lot of load, for example, for pitchers on their elbow. It's a very unnatural reaction to kind of load your arm, try and get this sort of lag to it and swing. So that's why a lot of people get Tommy John surgery or collateral ligament injuries, because now imagine doing that all year. Whereas, when we were changing sports, we're using different muscles, different forces, so it's not as much stress on that one body part. So that's one reason. Another big thing in children in sports, which actually goes a little bit more, it's not something I take care of, but ACL injuries. So for females, and the younger kids.
Tell us what ACL is. I apologize.
So ACL is the anterior cruciate ligament. So what the ACL is, a ligament that runs in the knee that prevents the tibia, which is your shin bone, from slipping forward from underneath your femur. So in females, even though we may see males get more ACLs, the reason why is that number's a little skewed because technically more males play sports. However, if you look at the amount of females that play sports to the amount of ACLs and kind of do that proportion, you'll see ACLs are a little bit more in females. The reason why is because of mechanics. So for example, now over the last 5-10 years in orthopedics, we've kind of with therapy tried to come up with techniques to help them. So for example, basketball players, usually when they jump, the females, when they jump, they usually land, and when they land, their knees kind of get a little knock-kneed. So they put a lot of pressure on the ACL, so they can get tears from that. So there's actually in orthopedics programs to prevent things like that, going as simple as, proper way to jump and land with that jumping.
Michael, I would assume that, again, one more time, when you do an assessment, you have to ask a lot of questions.
A lot of questions, a lot of history.
Just give me a quick rundown. We're down to the last 4 minutes of the show.
Okay, so history, what is the mechanism, if it's an injury, what's the mechanism of the injury? We talk about pain, how often it occurs, what the quality is it burned, is it sharp, how strong the pain is. Then we do a functional assessment. We have lots of tests to assess someone's function, how they walk, how they're able to, something simple, getting out of bed, getting dressed, or something as a high level, high skilled as playing sports. And then we ask the patient what their goal is. What do they want to get out of therapy? Sometimes, they know they were injured badly enough that they're not going to get back to where they were, but what is their goal?
Well, the most important thing that I hope that we can get out of this show is to let the people know that both of you who work for the same organization, although you have your own private practice as well, is that you collaborate.
Correct.
Collaboration, communication, that's the thematic, I guess, large sentence on top of good health care.
Yes.
Correct?
Yeah, I agree. I mean, I always tell patients all the time when, let's say I do an ankle fracture, no matter how well I put it together, there's me putting it together. There's the patient that has to, in a sense, when they go to therapy, put in the effort, put in the work, because no matter how well you put it together, if you're not working on that motion, you're not working on that strength, you're not working in the total rehab and working with the therapist, guess what? Yeah, your pain may be gone, but you're walking with either a limp or you have some stiffness and you can't get back to the things you need to do. So we definitely work hand in hand.
Well, like I said, we're now down to the last couple of minutes of the show, but I want to thank you both. I know that Michael Smith, you're located at University Hospital Medical Center up in Tamarack.
Yes.
And Dr. Woods, I know you work, I guess, throughout the system, the HCA system, correct?
Yeah, my main office is right in front of West Side, so it's 8251 West Broward Boulevard.
Right here in Plantation.
Exactly, right there, right across from the mall.
Never can tell. You may end up right here on University Drive. Right?
Yes.
So, anyway, what I want to underscore one more time, because here at Nova Southeastern University, we have 8 colleges that are in the health specialist division, but we have over 40 programs.
Okay.
So whether it's a physical therapist working with an orthopedic physician, or whether it's an occupational therapist working with a physical therapist, although for many, many years you never spoke to one another. but now you are, and you recognize each other's capabilities.
Yes.
Just because what you're really doing is you're working together for one person. That's the person that's watching this show, otherwise known as the patient.
Correct.
The patient is the one that is taking themselves and putting themselves in your hands, not to get your trained skills only, but to get your collaborative presentation of care. Is that correct?
Correct, I agree.
Patient-centered care.
Patient-centered care.
We wouldn't be here if it weren't for them, so we got to take care of them.
Well, that's why we have this show, because this show is dedicated to the health care of our community.
Yeah.
And like I said, we just we're now at show number 504, 505. So we've been doing this for over 20 years. And the greatest, I guess, good feelings that I get is the comments we get back from the public relative to how much better they have life quality,
Correct.
how much their quality of life has been improved.
Correct.
And it's because of wonderful people like yourselves that are trained well, and we try to make them aware of the wonderful people in our community. So thank you both very, very much. Dr. Clive Woods, Orthopaedic Surgeon Supreme.
Thank you.
From St. Kitts.
Yeah.
But you went to the University of Miami to get trained. And Michael Smith, registered physical therapist at University Hospital Medical Center. Thank you both very much.
Thanks for having
me. We
me.
appreciate both of you for being here. Remember, folks, I always say to you, you got to take good care of yourself. And you can't hold things back. I mean, if something's bothering you, you got to tell your doctor. I mean, even if you're in to see your cardiologist and you say, gee, my inside of my, I mean, it's really hurting. And I must have bought a new pair of shoes. I'm burning on it. Well, I'm not telling you have to go to every doctor to do every little thing that comes up, but you got to at least let somebody who's taking care of you understand that there's something bothering you so that they can make a decision. That's what they're trained to do. Yes. And that's what collaborative medicine is today. The medicine of tomorrow is here today.
Correct.
So let's do the right thing. And remember, as I say, if you have any questions, you have any thoughts, there's an email address right here and a telephone number. And I want you to know that this show is called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see ya.